Hi, I'm Ralph Preston, and it looks like we've got a pretty good crowd this week for our Tuesday morning Stroke Buddies Stroke Survivor Support Group meeting. This week, we're really lucky to have Patrick Reetz with us because Patrick's going to talk about gait. And gait is one of the most important things to most stroke survivors, especially if you're sitting in a wheelchair trying to figure out what's going to happen to you and how to get out of it and how to walk again. I'm going to let Patrick tell his story. He's going to do a little presentation, and we'll have some Q&A. And so, Patrick, how you seem like an empathetic person to me. People who become PTs, OTs in the healthcare business generally want to help other people. Tell us a little bit about how you became, what made you become a PT, and how a little bit about your experience and how you got to where you are with your mobile business these days.
Yeah, well, thanks for having me, Ralph, and thanks to everybody else for being here. It sounds like it's a good turnout. Like Ralph said, my name is Patrick. I've got a few letters behind my name there, and most of them are just really to make other physical therapists jealous and influence doctors. But I'm a physical therapist. I have a master's degree in physical therapy. According to the APTA, I'm board certified in neurologic specialty and geriatric specialists. I do own my own mobile clinic in Austin, Texas. It's called Performance and Recovery. We treat geriatric patients and neurologic patients in their own home, but it's not home health. It is outpatient level therapy in the home. And we're definitely going to get a little bit deeper into that further on because I want to get a little self-indulgent and talk about myself for a bit here. But I'm also adjunct faculty at Baylor University. I teach in the Doctor of Physical Therapy program there, teaching at the neurologic courses. I've also taught at University of St. Augustine, teaching the same things in the anatomy course there. I'm also on the physical therapy American Physical Therapy Board of PT Residency and Fellowship Education Council, which is another mouthful. And that has to do with me going to different hospitals across the country and doing the accreditation of new residency programs for physical therapy. So I get to see a lot of different aspects of physical therapy and people's recovery and how it works inside and out. There's, like it says, there's probably some other stuff I forgot. It may or may not be important. At some point, maybe I'll bring it up. About me. Um, so, like I said, I'm going to get a little self-indulgent, talk about myself here for a minute. I think and hope that it ties into my philosophy of recovery, how I treat stroke patients, and I will eventually soon get into gait, but I need to set the stage first. Like Ralph asked, how did I get into it? I started young. I was probably first or second grade, and my mom is a teacher. She taught special ed. And in the summer, for the first few years that I was alive, she didn't teach summer school, so I was with her. But then one year, I guess we needed money or something, and she says, I'm teaching summer school. You're going to have to go to your own summer school. And I went, and it was kind of boring. I was like, Mom, don't make me go back there. I don't want to go back. So she said, well, you can come with me and help these kids. I'm working with physically handicapped preschoolers and first, second, third graders. And they need help walking and they need help moving, and you could just kind of play with them and hang out. So I did that, and I would follow them to PT and OT, and it was fantastic. I loved it. I didn't realize it at the time because I was young, but it was kind of triggering a calling for me. So when I got into high school, I thought, wow, it'd be really cool to be a doctor. I would like to be a pediatrician, work with kids, help people out. But then I took math classes and I realized math is hard and I'm not good at it. It was kind of a punch to the gut that I probably wasn't going to end up being a physician. But, you know, being a teenager, I liked girls, and becoming a doctor wasn't on the table, and that wasn't going to get me the girls. So I played baseball. Right. I played different sports. I played volleyball, played a little bit of hockey. I also took an athletic training course, and that taught me, ankle taping and putting ice packs on athletes' shoulders. And that also planted seeds for me. It helped me see that, excuse me, that I could help people different ways. And when I got into college, I realized, okay, I want to be a physical therapist. I worked toward that. I started working at physical therapy clinics, working with athletes, people that are recovering from work injuries, surgeries, that kind of thing. And it was fantastic, and I really loved it. But a friend of mine who was a nurse at the time asked me if I could work at a rehab hospital. Excuse me for a second here. Dry mouth already, early in the morning. And I started working there, and it was in the rehab hospital in Whittier, California. And these patients were recovering from strokes, and it was a different sort of setting and a different thing entirely. And it really kind of blew up my perspective of what I wanted to do in my life. And I saw that, working with the athletes and working with people with ankle sprains, it was fun, and I could see myself doing that for the rest of my life. But working with patients with strokes, it was just another level. And getting people back to walking and back to their families, it held something much deeper for me than getting an athlete back to a high level of sport, right? And so I went to Fresno State and I graduated with my master's of physical therapy in 2006. And in the meantime, I was an amateur musician, still am, I guess. I took martial arts courses, various sports, all these things influenced what I did as a physical therapist. And so, with all that experience I had when I graduated, I was kind of a few steps ahead of most new grads. So, I first worked at Scripps Hospital in San Diego, and I was fortunate enough to work in the outpatient neuro department. It was an excellent learning experience. These people taught me a whole lot, these patients taught me a lot. And then I moved on to Rehab Institute of Santa Barbara and eventually made my way out to Texas, where I worked at Texas Neuro Rehab Center, which worked with a lot of brain injuries and different types of hemiplegia. And, I got to see different aspects. I worked in the inpatient rehab hospital there, I worked in the outpatient center. And after that, I worked in home health for a little while. And now I do this mobile outpatient. So I've seen the different settings that can help people recover from their strokes. And so I've got this overarching view of healthcare. And again, I like working with the stroke patients because it's just such a challenge for me personally. It's a physical challenge. I have to get in there and work hard, and I've never shied away from hard work. So that's something that really appeals to me still to this day. So as we take a overarching look of the healthcare pathway, this is what I think of with patients going through the healthcare system after a stroke. Now, maybe you skip some of these steps or most of these steps, but what generally happens is you go to the hospital because you're having a stroke. You stay in the ICU or the medical floor, and then you progress on to acute rehab, or maybe it's a skilled nursing rehab, which is also called skilled nursing facility. Maybe you do rehab and then skilled nursing, or vice versa. Acute rehab has a lot of therapy each day. Usually you get seen for about 3 hours total. And then if you graduate that, you can go home, and one of two things usually happen. Either home health comes to see you and you get nursing and you get occupational therapy and PT in your home, or maybe you go directly to outpatient and you go to a clinic for your physical therapy, occupational therapy, and speech if you need it. So when you're in the outpatient setting, usually the treatments are longer. Hopefully the clinic's seeing you for about an hour. Home health, the visits are more like 30 or 40 minutes. And very often in home health, you get generalists. Even I, when I was working in home health, I'd see a lot of knee replacements in elderly patients who are homebound. So sometimes it's not, home health is not geared quite so well toward stroke recovery. So we really want to get these patients into outpatient. Now, what I do now, like I said, is mobile outpatient. My clinic brings the outpatient clinic to patients' homes. So I bring that hour-long session and I bring different pieces of equipment. Obviously, I don't bring big equipment and bikes and stuff like that, but I bring as much as I can to help push the patient to the next level. So I definitely like to I love seeing these patients in the home because mobile outpatient is sort of like a marriage between home health and outpatient. You get the longer, more intense therapy of outpatient, but in the home setting. So, like when I have patients come to me, the big question is, what are your goals? What do you want out of it? Because a lot of therapists, I mean, we're required to write goals, right? And a lot of therapists will write the goals based on what they see and what insurance wants. I want to ask the patient what they want because the answer I always get is I want to walk. And what does that even mean? A lot of patients have walked in with a walker 50 or 100 feet and then they tell me their goal is to walk, right? And it's like, well, depending on your definition, you walked in. So what does that mean? Well, it means something different for everybody, right? Maybe you want to get rid of your cane, or you want to get rid of your AFO, or you want to walk better or faster or longer or whatever, or get back to running even. So you really have, as therapists, I hope good therapists really dive a little bit deeper and explore what the patient's goals are and create a plan of care based on what the patient wants, because that's what's important. Now, for me in the mobile outpatient setting, I accept Medicare. We don't accept regular insurance. We try to do direct pay, cash pay, which can be tough for some people, but we work things out with patients. And if I remove the insurance from the equation, now I don't have to worry about setting goals for them. So that really sets me up to help patients better. All right. So like I said, this outpatient level of in the clinic or mobile outpatient, that's the next level. Now, when you graduate from that, and that's a whole other loaded issue because some patients get kind of freaked out when they graduate outpatient, they feel like they're being abandoned or it's the end of the road or that's all the recovery they're going to get. There are other alternatives, and some other clinicians like personal trainers, athletic trainers, some wellness centers, gyms, stuff like that, alternative treatments. Those are one way to go where you can continue on your recovery. And it's a little bit more self driven because personal trainers generally aren't trained to be neurologic sensitive, and there's a lot going on with strokes. We know every stroke is different, and there can be weird symptoms that come up. So sometimes personal trainers aren't the best bet, but if you've graduated and you know your routine and you can kind of work on it, then maybe that works for you. So another thing that we like to do is what we call them outpatient frequent flyers, especially in the mobile setting. I can see someone once a week, once a month, and just kind of give them updates and little tune-ups, changes to their plan of care, check in with them, help them along to the next level. So sometimes when you graduate, it absolutely is not the end of the road. And getting in with someone who can continue to follow up on you, whether it's a clinic or a mobile outpatient setting, being able to come back and do it again and change things up and progress yourself to the next level, it's vital because recovery is going to take a while for a lot of people. Some people, maybe you're already 100% or whatever, but there's a chance that we can continue to improve you, and we'd like to see you more. So I've found that mobile outpatient seems to be the best setting now for certain people at that level. Now, it may or may not be in your area. You'd have to look it up online and see if there's a mobile therapist that can do this. And there's some mobile therapists that aren't set up to be neurologic specialists. Some are just going to work on sore backs and that kind of thing. But if you can find someone who is in your area, it could be a way to go. So I wanted to talk a little bit about language that I use, um, and relating to stroke. We've hopefully your therapists don't use good and bad when it comes to your sides, right? You've got the side that is affected by the stroke, the hemiplegic side, which that's the medical term for it. And then there's the other side, right? So if we call it good and bad, man, that's such a loaded issue right there. I really am not into that. I think most therapists have moved on from that. I hope. There's a lot of subconscious influence when we talk about good and bad side, right? I mean, we think about, like, if someone comes up with a camera to me and before they even click, here's my good side, right? I got to show my good side because that's the bad side. No one wants to see this, right? So that gets in your head. And if we start thinking of one side as bad, that can affect you and slow down your recovery. Now, I've seen a lot of other therapists say, well, we use affected or unaffected side, or more affected and less affected, and none of those seem perfect to me. And what I've come up with isn't even really perfect either. But when we talk about affected, like, the side that is affected by the stroke or more affected by the stroke, well, I mean, more affected and less affected is probably the best on this list, because the side that wasn't primarily affected can still be affected, especially if you have perceptual deficits, visual deficits, and strength is a global thing. When you've been laying in a hospital bed after recovery, everything's going to be weak. Everything is affected. So, we shouldn't be ignoring one side. Obviously we need to work on one side that is the most affected, but the other side can't be neglected as well. So what I've come up with is the recovery side and the performance side. I like recovery side because that's the side that we are working on and trying to get better. Performance side, I don't know if that's the best word for it, but it's what I've got at this point, for lack of a better term. So that's what I use, and that's what you'll hear me say as we go. Now, if you remember, but my clinic is called Performance and Recovery, Mobile Physical Therapy. So that all ties in. I want to make sure that that's something that I'm working on with people all the time, and just remind me, don't neglect both sides, right? So another aspect of language, you hear the term plateau, and that's another negative, bad word that I don't like to hear, right? Like I said before, you might.
If you go into your PowerPoint, it's minimized.
It is again. Maybe
Yeah, the other thing is, you might like this. I don't know if Leslie Hadley made it up, or she borrowed it from somebody else, but we like teaching and healing side.
Yeah, I sometimes use learning phase or learning side, education side, teaching side. Yeah, that's another good one as well. So,
It's so small for some reason.
Ralph,
Yeah.
his screen sharing is fine for me. It's not minimized. A lot of times, if you look, there's a little box with a green arrow coming out of it, and you're minimized. And if you click it, it'll come back to full size.
Not doing it for me. I just hopefully it's making it to the recording is all.
yeah.
Let's see what view we got going on here.
Ours is
I have it now. I went to full screen.
Does everybody see it but me?
Yes, I see it now. I didn't
Okay.
before. Thank
Okay.
you.
All right. Well,
If
as long as
Patrick,
everybody's
if worst comes to worst, I'll get it from you and I can
Yeah.
reinsert it all. That's a big editing job. Anyway,
yeah, that works.
go ahead. Sorry about that.
No, you're all good. Obviously, some people are better at Zoom than I am. So like I said,
Better than me.
all right. So, when it comes to that term plateauing, that's another one that I mean, I just don't straight up believe in plateaus. I mean, I do believe that out in the desert there are those mesas that go up and are flat, but I don't believe in a patient plateauing with their progress. Now, maybe your progress, maybe your recovery slows down or speeds up at certain times. Maybe you're in different phases where you are in more of a recovery phase or you're not. But the concept of plateau is something that is actually insurance driven or clinic driven. Administrators talk to us as therapists and say, this patient's progress is slowing down. They're not meeting their goals that we wrote out on paper that we don't even tell them what they are. And, we need to kick them out and make them come back later or whatever. So, we tell the patients, oh, sorry, you've plateaued. So, that again, that it's kind of something that's made up, really. If I've discharged a patient, hopefully it's because you were better. Now, what does happen, what I do believe occurs is we go through recovery phases and we have performance phases too. And so, like, what do I mean by that? The best example I can give, I hope it's a good example, is you look at football, right? NFL players finish the season, it's wintertime, and they're banged up. They need to recover from that, right? So there's a time in the spring where they're just resting their body and recovering and maybe going through rehab because they've got some injuries. And then as spring goes along and we start getting into summer, they have to get back into the gym and get back to their playing weight and their playing strength. And that's still a recovery phase. It's a little bit of a different recovery phase. But then they get into training camp and maybe they've got the strength that they're going to have. They got the speed that they're going to have. They've kind of ceilinged out there. But now they need to continue to do the repetitions every day in camp and catch the ball and do whatever they do. That's like a performance phase where they're really ingraining what they're doing and reinforcing what they're doing. Now, then you get to the end of training camp and then they put the pads on and then they really start hitting each other. And maybe the coach comes in and says, oh, I've got some new plays we want to run. Now, those are learning phases or recovery phases where they are putting in new information and trying to get themselves to the next level. So now they're back in this recovery phase. And then they get really good at those routes and really good at those new plays, but they still have to practice them a whole bunch, and then they're back into that performance phase. So I think that's a little more what happens with patients is that, we work on something and you've got it now, you've learned it. It's just like a musician, you learn a new piece. When you first learn it, you're in this recovery or learning phase, but then once you got it down, you have to practice it a few hundred times with repetition, and that's a performance phase. So sometimes you need the PT for the performance phase, sometimes you don't. So if you are in that more of a performance phase, that might be the time, especially with insurance, to take a little break, work on things, and then come back to therapy later when you're in the next recovery phase, when you've really mastered that thing that they wanted you to work on, and now you can push yourself to the next level. So that's what I was talking about, being a frequent flyer with outpatient. So that's kind of how I prefer to look at that whole thing. So another note that I don't really have up here, what I'm going to talk about today with strokes and gait is that we're referring to general typical hemiplegic strokes, not so much the cerebellum brainstem strokes with ataxia, spinal cord strokes, multiple strokes that are affecting both sides. And again, I hate to use the word typical or general, but what you think of when you think of a stroke with one side affected more than the other. So that's what we're going to cover with gait, and I swear we're going to get to gait at some point soon. So what is different in general about treatments for strokes? The one big thing right off the bat is safety. When I worked in those clinics with athletes and orthopedic injuries, you got to be careful not to injure the patient more. But with strokes that affect the patient, there are a lot of things to consider. There's balance problems. A patient may be on blood thinners. Maybe they had craniotomy. Some patients had their skull removed and still have it removed. So we have to worry about falls and other issues with patients who have subluxations in their shoulders. and looseness and hypotonicity in the shoulder, we don't want to be grabbing that arm and yanking it. And I see it a lot in like nursing homes where, just someone comes in to move them in bed and they grab that arm and just yank it right out of the socket. If we look at the term subluxation, what it means is that you've got the head of the shoulder going into the socket, and in a subluxation, it's moved out a little bit. Now in a dislocation, it's moved out entirely. So we don't want to turn that subluxation into a dislocation, and that can happen very easily if your therapist doesn't know what they're doing and they're walking you and holding on to that recovery side arm. So that's something to be really aware of and be very, very careful with that arm. So another aspect that's different, a major thing for me especially, is facilitation. So what does facilitation mean? If you look at the definition of it, it's to make an action easier, and that's a super simple definition of it. Now, when those orthopedic patients come in and they've got a rotator cuff tear, when I assess them, I want to look at their strength, the range of motion, and any problems in the joint. So what I ask first is, can you lift your arms? And they go, okay, yes, this arm doesn't lift up because of the rotator cuff tear, right? It's pretty simple. It's pretty straightforward. I've diagnosed it. I look and see that, okay, it's maybe weak and it's maybe restricted. It might be tight. Okay. So if it's tight, we got to stretch it. If it's weak, we got to strengthen it. It's pretty straightforward in the orthopedic setting. Now in the neurologic setting, especially with strokes, I'm going to do the same thing to start. Can you lift your arms? And it looks like this. And yes, it may be because it's weak now, maybe because there are tight things in there. But the other aspect is that the connection between the brain is not getting to the arm. In your head, you want to lift your arm, and your arm, the muscles, there's nothing wrong with the muscle or the bone, right? It still works. It wasn't damaged. It's just the connection between the two. So as therapists, what we need to do is facilitate that motion. All right. So facilitation can be as simple as me demonstrating it. Hey, it looks like this. Or I put a mirror in front of them so that they can get that feedback to how well are they raising their arm. Other methods of facilitation involve me putting my hands on them. And I like to start as light as possible. I want to give the minimal amount of assistance to get that facilitation. If I grab the arm and lift it, that doesn't do anybody any good. So gradually, lightly, gently working on facilitating it, that's the method that good therapists can use to improve your arm motion, all right? So another big aspect is neuroplasticity. And I think you've discussed this before here. I think Dr. Hetzler did a fantastic job on an hour-long discussion about neuroplasticity. He dove really deep into it. It was fantastic. I'm going to sum it up in a ridiculously overly complex, way too simple term. It's the brain learning to do a thing. Okay. So when we look at the brain, here's a chunk of your brain, and this part of your brain moves the arm up. Okay. And you've got a blood vessel that comes here and it supplies this whole area. But in a stroke, that blood vessel got occluded or it ruptured and bled out. So this part of the area, this part of the brain was damaged, right? Right in the middle here where the blood vessel attaches, it didn't get blood and it was damaged the most. Now this next area out here, it got damaged kind of medium, and the area further out got damaged light because other blood vessels are coming in and still supplying that area, right? So this whole area that controls your arm was affected because when you're not getting blood, you're not getting oxygen, and your brain really likes oxygen, right? If I put a tourniquet on my arm, you can leave it there for half an hour and it doesn't feel good, but your arm isn't going to die. Your brain, if I cut off blood supply by pinching my carotids, I'm going to pass out really fast, right? So the brain is super sensitive to that oxygen and lack thereof. So when we consider neuroplasticity, this section that controls the arm now is damaged, and these nerves come up to it, right? Well, what happens is that these nerves are going to move. They're going to move down to another part of your brain, right? This other part of your brain down here has never moved your arm before, so it needs to learn to move your arm. Now that's a pretty challenging thing because it's lived your whole life, and some of us are 40 something. I'm seeing a few of you out here that are a couple years older than me, right? So a couple few years older than me. So you've lived your whole life. That brain has gone quite a few decades with this part of the brain has gone quite a few decades with never having to do that. So it's having to learn to do that now. So that's a huge challenge. It's like if I want to learn to play the saxophone, I've never played the saxophone. I got a music background. I got the basic idea of it. I know you put it to your lips and blow and do this with your hands. And, I could probably learn to do it. It's going to be slow. There's going to be a part of my brain that's now the saxophone center. Okay. And it's going to take some time to learn. Now, if I had learned when I was 4 years old, I would have picked it up a whole lot faster than now in my 40s. It's going to take me longer to do it. So this neuroplasticity concept, it's like I said, it's the brain learning to do a thing. It's just part of your brain learning to do a new thing that it's never done, even though you used to already do it. So it's, like I said, it's obviously there's a whole lot more to it. Check out Dr. Hessler's video. It's fantastic. But for now, we're going to run with that and consider that in our stroke treatment. So gait, the thing you're here for. Half an hour in, I'm finally going to talk about gait now, right? So what is gait? It's the hinged opening in a fence. Thank you so much. Have a good day. Appreciate it. All right, kidding. So what is gait really? By definition, it's how you walk. It's your walking pattern, okay? I had a professor tell me it's falling forward and catching yourself over and over. You lean a little bit forward, you start to fall, you throw one foot in front of the other. If you read Douglas Adams' work, the guy who wrote Hitchhiker's Guide to the Galaxy, one of his books, he said, the trick to flying is to throw yourself at the ground and miss. All right. And clearly it's the second part, the missing, which presents some difficulties. So since none of us are going to be flying anytime soon, I hope, walking, that's the challenge. Throwing yourself forward over and over and catching yourself. Well, we want to look at normal gait first, because without that context, I can't really talk about gait with the stroke pattern. So we're going to look at the gait cycle. The gait cycle is when my heel is on the ground to the next time that same heel is on the ground, right? So my left foot leaves the ground, that's the heel coming up, to the next time it lands. And that's about 1 second. Okay, so this happens really, really fast, right? So we're gonna look at the Rancho Los Amigos Rehab Center. They quite literally wrote the book on gait. All right, so I stole a little bit of a picture off the internet. And like I said, the whole cycle starts when this heel is on the ground, swinging through, blah, 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 and landing again, okay? So we break it up between stance phase when this leg is on the ground, and we're just going to say it's the right leg because this is non-stroke gait. And another section of it is swing, when it is up off the ground, it is not in contact with the earth. That's your swinging phase, all right? So we start with this foot landing on the ground, all right? You have to have your toes up a little bit so that your heel lands. It's called heel strike. There are some therapists that use different terms now, initial contact, because, like I said, some of us don't land heel first. So when the foot lands first, that's initial contact. Now this leg just kind of has to be forward. Right before this, there isn't any weight through the leg. We're landing right there. Now, as this back leg starts bending and coming forward, this right leg that's on the ground goes into a loading response. This muscle right along here has to fire in order to keep the legs straight so that you don't fall to the ground and collapse, okay? So this muscle firing is vital for any of the rest of this to happen. We also want to look at the hip here. This hip has to remain strong. These glutes have to start firing. These lateral hip, what we call abductors, the other glutes, the glute medius, they need to fire so that the hip doesn't collapse as this leg as the left leg starts to come through, this right leg ends up behind us, right? Now we actually need this front of the hip to be flexible. You see how he's got this leg almost behind him now? If this leg doesn't end up behind him, then we can't move into the next phase, because the legs, what happens from here to here, the knee actually just bends. It actually relaxes, and momentum starts to swing the leg forward. Again, we're moving forward through this, and this leg starts coming forward. It picks up off the ground. It's not an active thing that we pick this leg up. It's just momentum. It's relaxing. We do have to lift these toes up, or again, we're not getting this toe off situation. But as we come into the swing phase where it comes up off the ground, there's not, it looks like we're kind of lifting it, but we're really not. It's mostly momentum. And then we give a little bit of a kick out at the end to swing it through. So what I'm trying to say is right through here, there's not a lot of active motion. This is just momentum, a relaxation moment where you've got some stored up energy where this leg just kind of comes forward like that. We do have to have some muscle work in the toes to lift it up to get to that next heel strike. But we're not using the quadriceps and the glutes through this swing phase like we are in this stance phase. So as you see, the stance phase actually is a larger chunk. It's actually about 60% of the whole 1 second gait cycle. So you're on this leg longer than you are with this leg up in the air. So more muscles are involved. It's more, dare I say, important to the whole gait cycle. Now, if we consider what happens during a stroke, with someone who's had a stroke, well, obviously we've got this leg coming forward already. So, right, so this is the context we're seeing, and this leg is coming forward. So like I said, if this muscle doesn't fire, we're going to collapse down on this leg. So quadriceps strength is important. But the other thing that could happen is maybe we've got some spasticity through here. Maybe this leg is working too much. Maybe this ankle is working too much, and your foot is plantar flexing, pushing down into the ground and causing your knee to snap back. And so what I see right here in this section is either this knee tends to want to collapse in abnormal gait, or it slams back into hyperextension. Okay, so those are two big things that I see right there. What I also see, like I talked about, these glutes need to be strong, but the front has to be loose enough to let that leg come back behind you. If this leg doesn't come back behind you, your performance side leg isn't going to be able to step out here. If all this hip is collapsing, this leg comes up and then it just kind of plops right down right there. So you get this leg stepping out, and then the performance side leg doesn't step all the way through. So you get a gait that's kind of a 1-2, 1-2 like that. Okay. So again, this section is so important. And in the early phases of gait, I'm really in there with the patient. I've got my hands on them. I'm making sure that this leg doesn't collapse. I don't worry about this quite so much in the early phases. I maybe put an AFO or an ACE wrap on the foot, or maybe I put a plastic slider over the toes, and I just kind of move that foot forward, and I don't worry about that part. This is the part in the early phases that is going to really stimulate recovery. So why is that? Well, in this phase, this other leg is up in the air, right? We have all of our weight on that right leg, or at least we should for a moment, okay? Now, I don't have the view, but if you were to watch this person walk from behind, what has to happen is some lateral weight shifting. We don't walk straight like this. It would be kind of clunky. We have to move our weight left and right. I'm watching Jackie here. I think you're walking on a treadmill while you're watching this, right? I mean, there's your example. There's an example right there. She's shifting her weight side to side as she walks. If she held it in the middle, she wouldn't get very far, or you'd tire out really, really quick. So watching the patient from behind, they need to shift that weight onto the recovery side, this right side, as this left leg swings through. So to me, that is so much more important in any phase. There's so much to talk about. I'm trying to not go too far into one thing and really pay attention to the other things I need to talk about here. So keep that in mind. Lateral weight shifting, shifting your weight onto the recovery leg is vital. Usually, once this is going better, I start focusing on this and refining the patient's ability to step a little bit further. But I find that if we get this down, this part, the swing phase, it just comes along. That part happens, and then we can go back and start refining things and smoothing out the gait pattern. Okay. So when we look at my philosophy of stroke gait recovery, the first thing I do, and the thing I do all the time, is the idea is that I want to fix what's going wrong. No duh, right? That's why you're here. Your gait is going wrong. You need therapy to fix it, right? So the thing is, though, that we always have to keep that in mind, all right? So I always want to consider, that's why I talked about normal gait and stroke gait. I want to keep in mind what's normal. And like I said, normal is a range. You can watch 100 people walk and watch 100 different gait patterns, right? But it's within a range. If you're walking and you're doing this, that's not normal. If someone who hasn't had a stroke is doing that, you're going to wonder what's wrong with them, right? So, we're always keeping in mind that normal range and what we can do to fix what's going wrong. Now, a good starting point for you, like I said over there, looking at the gait pattern, I start with that. Well, we want to get lateral weight shift, right? I'm already getting ahead of myself. So always go back to the performance side, right? If your stroke side is your right side, if your recovery side is the right side, what is your left side doing? What is that performance side doing, right? I talked about having to weight shift. When I tell patients, well, shift more weight over to your right, shift more weight over the recovery side, that doesn't always click because we don't have the same connection over to that recovery side anymore, right? But what we do have is much more control over the performance side, right? The non-involved side. So what I tell patients is step bigger with that performance side, right? Focus on improving quality of movement of that side, because if you are taking bigger left steps, then you are putting more weight on your right leg, and putting more weight on the right leg is the problem. It's not putting enough weight on the right leg, right? So focus on what you can control first, okay? And like I said, weight shifting is key. Being able to shift your weight over there. So, I look at actual gait and then I look at pre-gait. So pre-gait applies to everybody, whether you can walk or not. We need to stand up and just work on shifting your weight side to side, and shift your weight and hold it there. Shift your weight to the performance side as well, and make sure we're going the appropriate amount, the same amount side to side. Maybe having that mirror in front of you is going to facilitate that motion from side to side. And doing bilateral exercises is also really important. Mini squats, partial squats. I like quarter squats, not very deep. I don't want to strain anybody's knees, but going down, up and down, again, with the mirror in front of you to make sure we're not cheating. That's really vital. You can also do, maybe if your ankles are strong enough and you're not in an AFO, you can do heel raises, again, making sure you're even on the same side. And like I said, weight shifting side to side is really important, but putting one foot forward and one back and shifting your weight that way, where it's sort of forward, but it's also side to side. It's almost like a diagonal weight shift. That's also another pre-gait activity. And then just stepping that foot out and back repeatedly is also another activity that I work on with people, right? And again, both sides. Why not start with stepping out with that performance side? Because again, that's forcing you to put weight on the recovery side. The more weight that right leg, that recovery side leg gets, the better it gets at supporting you. And that's all about that stance, phase, and gait that we talked about that is super, super important. Another thing that you can usually control, posture. Make sure we got the posture. That's a whole body thing. That's spine. That's, maintaining that good posture. Half of y'all sat up when I said posture, right? So making sure that we're maintaining that good posture, both in pre-gait and actual gait. All right. And I I maybe put these in a weird order. I went back and put little asterisks here. The asterisks, I think, are things that y'all can work on a little bit more on your own. The other things are a little bit more therapist driven. So a big aspect that goes into what I do with patients is what I like to think of as forced use training. Okay. And in forced use training, like I said, I always ask patients what their goals are and try to work on what they want to work on, improving their quality, and facilitating what they need to do to improve their quality of life. Maybe it's removing the AFO, maybe it's taking the assistive device out of the equation, getting them to go faster. What I like to do is go directly to that. And that's where you need to use caution. Some therapists aren't capable, physically strong enough to do this. It's something you may not want to do on your own. You don't want to, if you've been using a cane for quite a while, let's not just ditch the cane on your own. Now with me and my patients, I do exactly that. I make them walk about 10 or 15 feet with that cane, and then I will grab the cane and just throw it. It's a nice dramatic moment, and it kind of scares them a little bit, but I say, don't think about it, just keep walking. And I force them to take that next metaphorical step. Maybe if they want to get rid of the AFO, let's get rid of the AFO and go. You might roll that ankle, but I'm going to be right there to make sure it doesn't happen. So I am definitely going to push the patient to do something that's a little bit out of their comfort zone. And that's really a good way to push patients along and get some improvement. And for me, this relates to what's called constraint-induced movement therapy. Maybe you've heard of it. Maybe you've had that done to you. Maybe you've seen it. It has more to do with OT and hand recovery. But what they found is, if you got a recovery side, this side isn't working very good. Your other side, the performance side, is doing just fine. You're going to brush your teeth with it. You're going to eat your food with it. It's just going to do all the work, and the recovery side is just going to sit there. If we wrap this up with a mitt, if we wrap up your performance side with a huge glove or a towel and just physically take it out of the equation, we are forcing that recovery side to do all of the work. All right. And research shows that forcing it really speeds up recovery. Now, you consider that in the legs. Well, I'm not going to take someone's performance side out of the equation and make them walk, because then we're just walking on one foot, and that doesn't go well for anybody. So the thing is that every time you're putting weight on that recovery side, we're forcing it to do more work. But we want to make sure that we're putting enough weight on it. We want to force it to have to do more. So anytime I can take away someone's cane safely or a walker or whatever, we're going to do that in therapy. And again, it might be kind of scary, and we got to use caution with it. If your therapist isn't capable of it, or you're not capable of doing it on your own, definitely, don't be doing that, because I don't want anybody falling and, oh, Pat said, let's just take away that cane, so we just got to be careful with it. But that is a huge component to what I do. Right now, another issue is context and your learning environment. All right. So back when you're in school and you're studying for a test, you got one of those math tests that are super hard, no one likes. It's coming up, and you had to study for it. You probably didn't do real good if you're studying right in front of a TV blaring at you. You probably didn't do really well if you studied super late at night when you were exhausted. If you're not focused, studying isn't really going to work for you. So you always have to consider your learning environment, the context that you're doing something in. I like to start patients off easier if they're early on in their stroke. I'm not going to make them walk down the street with all these distractions and safety issues. That's why people walk in rehabs. I mean, it is flat surface, and everybody's going to get out of your way. So we want to start a little bit easier and then progress to more challenging environments, adding obstacles, different surfaces, walking on grass, walking on sand. So we really have to consider what is going on around you. People like coffee, right? Some of y'all are coffee drinkers. drink, if you like coffee, drink it before therapy. It speeds up the brain. It will actually help improve your ability to get some neuroplasticity and make some new connections. So there's actually some research behind that. So if you don't drink coffee, I don't want to advocate that you start up a crazy semi-expensive habit, but if you are a coffee drinker, drink it before therapy and time your therapy sessions at those good moments of your day when you're most focused and you're most able to do these things, because there's kind of no point to doing them in the middle of the night when you're exhausted anyway. All right. Coffee, caffeine, it's fantastic. So another thing that I consider is how am I facilitating? And you may have heard these terms: NDT, which is neurodevelopment technique or neurodevelopment therapy, or NeuroIFRA. I think that someone else who presented a little while ago, Shannon Cobb, I think, in February, she was a NeuroIFRA trained therapist. I'm also NeuroIFRA trained, and I'll come back to it, but the opposite basically is proprioceptive neuromuscular facilitation, PNF. Now, massage therapists and athletic trainers, personal trainers have kind of co-opted PNF, and they take a couple of specific techniques, stretching and things like that, and they say, oh, I do PNF. Well, PNF was developed by a couple physical therapists and doctors back in the 60s, I think, and it is an entire system of stroke rehabilitation. So it's one of the older systems, but I wholeheartedly subscribe to it. If we look at facilitation, we go back to what I said. It's facilitation is helping someone move, increasing the ability to make a movement. There are two main ways that I facilitate motion. I might help that patient. I might put my hand on them and go with the motion. I might really lightly, gingerly, get the patient to move by doing really easy, light touch and trying to inhibit the wrong things that are going on. PNF kind of takes the opposite approach. If I ask you to raise your arm, I'm actually going to push against you and make it harder for you, right? So, I mean, what happens if you put your arm out and someone pushes on it quickly? You're going to push back, right? So that's my way of facilitating a stronger push against me, okay? So PNF tries to take that concept and run with it, really. So you might have had PNF diagonals where they're resisting you on a diagonal pattern. I think that someone else, Mitch Raymond, he talked about that too, diagonal patterns, and I take those and change them up based on what the patient actually needs. But the general concept is that I'm going to push against you and try to get more muscles firing to get that motion to happen. Now with NDT, I'm going to lightly put my hands on you and help you learn the motion, right? There's a time and a place for both of these techniques. I sometimes go back and forth. Some patients respond better to one or the other, depending on what's happening, what I see. I go down a different path. I think that if a therapist is just gung-ho on NeuroIFRA and isn't going to do anything else, well, that's great. That might work, but that's using a hammer on every problem, right? Every problem looks like a nail when all you've got is that hammer. So it's nice to have more tools in your bag to do different things. Proprioceptive neuromuscular facilitation really strengthens, because I'm physically working against the patient and getting the muscles stronger. So that ties into the next thing, exercise. Another no duh Mr. Therapist moment here, right? Exercise and strengthening is going to help your gait, right? So we do look at the performance side, do strengthen both sides. Bilateral exercises are fantastic. They kind of take a little bit of the safety factor out of the equation. Mini squats are fantastic. Bridges, my God, that's right there. If you take one thing away today, do bridges, please. Bridges are fantastic. They strengthen your glutes. They work your core a little bit. They work the knees. They even work the ankles. And y'all know what I mean by bridges. If you're laying on your back, you got your knees bent up and you lift your butt up to the sky. Okay. I didn't throw a picture in here, but That's an excellent exercise. Now you got to make sure that your recovery leg isn't going to roll over. That ankle is nice and stable. You might need to spread your feet apart a little bit. You might need to start on a more solid surface, which presents a challenge because the floor is more solid than your bed, but you might have trouble getting on and off the floor. So if you do it on a bed, hopefully your bed's firm. If you do it in therapy, obviously the mats are great. If you can get on and off the floor on a yoga mat and do this, it's excellent. So always do bridges, trying to lift your hips up as high as you can. And everything is a progression, right? We can progress on to single leg bridges. We can bridge and then march. I can put your feet on a pillow or a little rocker board and make that bridge really hard. So there's always ways to progress things, but man, bridges, like I said, if you take one thing away, please make sure bridges are a part of your routine. I have yet to find a stroke patient who wasn't going to benefit from bridges, right? Other bilateral things, stationary bike, standing side kicks, leg press, stuff like that. That's all fantastic. And don't be afraid to make sure you're strengthening that performance side, because again, it's kind of the low hanging fruit. We can do it, it's safe, and it will affect the other side. The brain is connected, right? And that's why we talked about earlier, like, there's a recovery and a performance side. It's not a good side and a bad side, or a working side and a non-working side. The side that is affected in your brain, well, those nerves from the performance side are going up to the other side of the brain, but then they cross over through the corpus callosum. Your brain is you don't have two separate brains. You don't have a right brain and a left brain. We think about it that way sometimes, but really it's one. No one thinks, well, my right brain's going to do this now, and my left brain. No, it's all together. So definitely strengthen things, and hopefully that helps with some of the gait. Now, when I look at phases of recovery, stages of them, the first thing, those early stroke patients, just getting moving and walking with or without a device, that's kind of step one. And this is sort of the cutoff for me. When you're in rehab and you're just trying to get from point A to point B, I'm just maybe walking you 5 or 10 feet or something. This is the first step. And when we progress on to this level, being able to walk without me physically holding on to the patient, without someone assisting you, it kind of opens up a whole new world. So now we're working on refining the quality of gait. So what happens in these early phases, I got my hands on a patient for safety, to make sure that the leg even moves, to help get them moving. And then I want to work toward backing off that. And then when we get to this point where you can walk without physical assistance, that's great. Now I put my hands back on the patient to fix what's going wrong and to refine the specific issues that are affecting your ability to walk more normal. Now we start adding in other higher level gait activities here as well. Sideways walking, backwards walking, walking over obstacles, walking slalom through cones, walking on grass or sand or through water, any other higher level stuff here, we can throw that in there once you're able to go without physically being helped. Other big benchmarks that we want to get toward is being able to walk without that device. Now, I mentioned that, sometimes in therapy, I just take that cane and throw it away, or say, forget your walker, let's just go. Now, maybe we do that just in therapy and you go back home and use the cane, and that's fine because we want you to be safe on your own. But we do want to work toward that, right? So that's a pretty common goal, is be able to get rid of the device. You probably didn't walk with a cane before the stroke. We'd like to get you doing that as well. Same thing with the AFO. If you have to wear an AFO, I had another slide that's going to dive into this a little bit deeper, but walking with AFO may be super necessary, but if it's a goal, we're going to work toward that as well. And if you get to that point, that's another huge milestone for you. And then really getting into refining things is being able to walk without obvious deviations most of the time. So like if someone off the street watches you walk, they're not going to say, oh, he's limping or he's got a problem. So most of the time you're able to go without that, without any deviations. Now, when you get to the point where you're walking without any deviations all the time, you're getting pretty close to being fully recovered, maybe, depending on what your goals are. From there, we start working on walking faster, and we're going to come around to running as well. All right. So ditching the AFO, it's a very, very, very loaded question, right? Now, if we're going to even consider taking that AFO off, if you've been wearing it for a while, there are a few things that we need to address. You must be safe. That ankle must not be rolling when you stand on it. There must be no risk for you falling. It must be pain-free. If you're standing on it and it's hurting, there's a problem. If your knee is hyperextending without the AFO might be stopping or at least reducing that knee hyperextension. And we don't want the hyperextension, because the more we hyperextend the knee, the more we stretch the ligaments in the back, and then before you know it, your knee is going to be bowed backwards. So, we'd like to eliminate or reduce that knee hyperextension. So now, if you do need an AFO, I definitely recommend getting a custom fit AFO. A lot of clinics or rehabs, maybe at first they get an off-the-shelf AFO, a fixed one that doesn't move, one that isn't custom fit to your foot. And those can cause pain and just not be comfortable in general. But hopefully they take a mold of your foot, make a custom fit AFO, and one that bends a little bit to allow your ankle to bend forward when you walk, but is fixed at 90 degrees and holds your toes up so that we reduce foot drag. Now, the reason you're probably wearing an AFO is one of two reasons, or combination of it. Maybe your dorsiflexors just don't work and your toes are not able to physically lift up, and it's flaccid and your toes just kind of drag. So the AFO helps lift those toes up so that we don't hurt our toes when we walk, and actually improves quality. But the backside, your calf, your big calf muscle, might be spastic and forcing your foot down into plantar flexion. The AFO is going to fight that and functionally do the same thing at the end of the day, but it's kind of for different reasons. Now, you may have a combination of the two. Generally, if your AFO is strictly to assist the foot drop that's passive, that's a stronger pathway to being able to get rid of the AFO. If you've got a lot of spasticity in plantar flexion pushing that foot down, especially if it pushes down and in, you're at much higher risk of rolling the ankle, and that's going to be a more challenging pathway to get rid of it. So, and that brings us to, how do we get rid of it? Well, repetition. Working on lifting the foot. When we say dorsiflexion, that's the toes coming up, right? And I say toes, but really the whole of your foot coming up, right? That's dorsiflexion. And it's great to sit here and be able to lift your toes up and down while you're sitting, but that's with your knees bent. We need to do it in different positions. When you're laying down, bring your toes up. When you're standing, bring your toes up. Like when I'm sitting here, especially if I got my foot out a little bit, my toes come up quite a bit. But if I stand, maybe they only come up 15 degrees or so. So it's a different challenge to be able to do it in standing or sitting. One exercise that I love, and again, this is a loaded issue because maybe you don't even have dorsiflexion at all yet, but if you've got some dorsiflexion, if you're able to lift those toes up without your AFO on, sit down, lift your toes up, and then kick your knee out straight. What you're probably going to find is that you can lift those toes up, but then as you straighten out the knee, the foot points downward. I can't make the camera work. Right? So we pick our toes up. As we kick that knee out, the toes start pointing down and in as the knee extends. So when you walk, our knee isn't bent toward the end. When we're landing with the heel on the ground, our knee is actually straight, right? You don't walk with your knee bent all the time. When your foot lands on the ground, your knee is straight. So we need to be able to lift those toes up while your knee is straight. So sit in a sitting position, bring your toes up, kick that knee out, try to maintain the toes up, the whole foot up. That's the big challenge right there. So there are huge factors that limit our ability to progress after a stroke. Spasticity is a big one that I've just been talking about. That can limit your ability to improve. Botox is a good way to counteract that. Some medication, progressive stretching. I do that when there's a lot of spasticity. You just got to be really careful and stretch the muscles properly without pain. Heating pads sometimes can help, but that's also a loaded issue. If you got sensation issues, if you can't feel it, I don't want you to get burnt by wearing or by using a heating pad. Apraxia is another big challenge, right? Apraxia is inability to learn new motor skills, and it's generally related to receptive aphasia. Okay, and aphasia is inability to produce language. Now, there's the aphasia that is I'm not a speech therapist, obviously, here. So receptive aphasia means I don't understand language coming in, and then I forget the other term, but aphasia going out is your inability to express yourself. So usually when we say aphasia, we think of like, oh, we can't get the words out, right? But the other side is receptive aphasia, where you can talk to someone and they just don't get it because they're not understanding the language. Apraxia is very related to that. Obviously, if I'm telling a patient do this and do that, and they've got receptive aphasia, it's going to be hard to teach them. So the same thing, apraxia is pretty related to that inability to create new motor pathways and learn new motor skills. All right. Other things that are a concern that I have to keep in mind: orthopedic complications. I get patients who went in for a knee surgery and ended up with a stroke, right? Well, now they got a knee problem and a stroke problem. So if they've got other issues, especially if it's involving the performance side, maybe they needed a knee replacement and they never got it, and now they're putting a whole bunch more weight on that performance side. You're going to grind down that knee even more. So we just got to be really careful about that. Pusher syndrome. There's another one that I could talk about for an hour. If your stroke was on the right side of your brain, the right side of the brain is involved in perception of space. And if that is affected, a lot of patients end up pushing themselves over to that right side because they feel like there's too much input coming over here and they lean away from it, and this becomes upright to them. It feels like they're right here, but they're right here. And you put a mirror in front of them, and sometimes they're turning away and they can't even look that direction. So you put that mirror in front of them and hopefully they start seeing that, okay, this is middle. It's a really big challenge to improve that. So I wanted to get to running. I kind of feel like I'm running through the end of my slideshow here. I had no idea that I was going to be able to talk for a solid hour on this, but hopefully everybody will have time for some questions here. Running is absolutely something that I could talk for a solid hour on. It's like we might have mentioned before, it's a huge step above just being able to walk. Now, maybe that's not your goal, but being able to run at least a little bit is a pretty vital human function. Like if a bear is coming at you, you need to run a few feet, right? At least. So it is good to be able to do it. Now, my requirements for running is having very, very, very strong ankles, being able to do not just a lot of calf raises, but being able to do calf raises on one foot. So you can imagine that maybe you can't even do a single calf raise. I want someone doing 30 at least. So I have really high benchmarks for being able to run. If your ankle isn't that strong, it's probably not strong enough to run on yet. I also look at jumping, and I look at jumping as a progression. Being able to do one big jump up and down is step one. Step two is hopping, which is kind of a different motion, right? And then hopping up and down turns to hopping side to side, which is bounding side to side, pushing off one side to the other. So I want my patients to go through that whole progression before we can even consider running. And then I also want to see them walk as fast as they should be able to. And that's a little bit of a subjective loaded sort of statement. But if I have them walk and they walk at this speed naturally, and then I say walk as fast as you can, and it's a little bit faster, that's not enough. It should be like double, right? What would normal be? Normal would be significantly faster. So I sometimes just grab the patient and push them to go faster. And if they can't handle that, then running is not really on the table yet. So the next step is to start running in place. And if they can do that, then we just go for a run. And, this is something I do with a lot of my younger patients. It is a very big challenge. It's a safety concern because when I'm walking a patient, it's usually pretty slow. I can keep my hands on them. Running, I got to run with them. So not only do I have to be in decent cardiovascular shape for a change, I have to be able to catch them if they fall. And I've had patients fall while running, and it kind of turns into just a controlled fall of both of us going down. So it's a big challenge. So running is something, again, I could talk about that for quite a while. So that's what I've got. And I having done this now, I feel like, man, that is such a huge amount of information. So I hope that you got something out of it. I am very happy to answer questions, and I hope that it's not too late for that. Ralph, what do you think?
No, I'm fine with it. I got one that you'll like from early on. I have a friend who's a PhD therapist who says there's no such thing as a plateau, just a therapist who doesn't know what to do next. And you introduced the insurance company aspect, so maybe we ought to cut therapists a little bit of slack and say either a therapist that doesn't know what to do with or a therapist that's being driven by your insurance company.
Absolutely. Just, I hate to throw anybody under the bus, but I feel like it's kind of lack of creativity. There's so much to do with stress. I mean, that's why I could talk about it for so long. It's just there's always something else to do with people. I mean, there's always more goals. There's more things. So, unless you're fully recovered, I'm going to keep working with people if I can.
Well, I find the people that do best are ones who are able to adapt. They also have a mindset that they're not going to get stopped by something as simple as I don't have one of those or I can't do that. Okay, well I can't do that, so I'm going to do the parts of that until I can do that. If you have that kind of a philosophy, you're more likely to get better than if you see everything as a brick wall. I can't do that yet. Yet should be the word. And you should try and figure out how to break it down so you can put it back together and do it. So that's just an observation on my part from working with people.
Cool. I think, is it Pierrette? You have a question?
That's perfect. That's absolutely perfect. Can you hear me?
Yes.
Okay. So I live in Canada, and thank you for your session today. And sorry for having to jump out earlier. I had another crisis going on. But I'm a right side hemiplegic. I have leg drag. I have hyperextended knee. I have foot drop, and my leg drags all over the place. It's not a pretty picture, I'll tell you that. I have an AFO, and I've had my stroke 5 years ago, and the AFO is helpful when I'm going outside because I wear the AFO to give me a little more strength and confidence. I think I've never really had ankle roll or anything like that, but I have hyperextended knee, and so sometimes I can be a little bit wobbly. But I found that wearing the AFO, because it's not really fully flexible, doesn't allow me to fully bend the bottom of my foot.
No?
And so I've done what I can to stop wearing it around the house. I wear it when I'm outside. And I'm wondering, is 5 years a long time to be wearing an AFO, or what is your thought on that?
Yeah, absolutely. I mean, 5 years is a long time for a lot of things. So, that's going to kind of rewire a lot of things in you. You've been walking for a long time with your foot. Now, does it have an articulation? Does it allow the foot to come up more?
I have some now. I have some of that. I'm allowed to raise my toes up a little bit. My hand is not fully functional, but it's better than it was.
Okay. Yeah. So, I mean, your foot, your brain have gotten used to wearing this AFO, pretty much all the time with walking until recently you're able to, like you said, go without it inside. So, it sounds like you're on the right path, progressively reducing the time that you're wearing it and doing it in a safe environment inside first. That's the way to go. Doing some of those really simple exercises, the weight shifting, getting the ankle used to it. That's a great step one. And then of course, actually walking without it inside, again, in a more controlled environment where you can be safe. That's the progression. If you can do that more and more and start building up your speed, and if it's hard to say without watching you walk, but if you're getting some toe up while you're stepping and with that heel landing rather than landing flat foot or toes first, then we're on the right path. And making the jump to walking with it full time, that's a pretty big step, but that would be great if you can get there. Like I said, continue to strengthen those dorsiflexors, continue to work on raising the toes, and particularly being able to kick the leg out and maintain those toes up. That's really going to take you to the next level with it.
Okay.
Okay.
Mm-hmm.
I usually recommend, I'd say ankle, ankle, ankle if
Right.
you're trying to get off. And you made a very valid point. I've helped a couple people get off AFOs, but if they have much supination or ankle roll, they're scary. They're dangerous. In fact, you're not as good how did you put it? You're on a more difficult pathway. Yeah, well, because of the, potential harm you could do to your ankle.
Sorry, Jasmine. I have to do friends.
But if you don't have ankle roll, it's a good. There's a fairly, I wouldn't call it easy path, but there's a lot more obvious path because you're dealing in the one plane. So dorsiflexion, plantar flexion, heel raises. I like heel raises on the step because you can dip below grade and they become heel and toe raises.
Mm-hmm.
Also, your weight will help force a little bit of a toe raise. Also, steps have, if you take the steps coming up to your house, most have got two railings, so you can work either side and put the railing on your strong or teaching side. So,
I have two questions.
Brett, I have William Blow and I did a conversation on AFOs. I'll try and I'll find you on Facebook and messenger it to you.
I have two questions if there's time.
Sure.
Okay, one of them deals with weight shift. I read an article several years ago that stroke patients put more weight on their non-affected foot and leg than on their affected one. And in this article, they tried to improve gait by having a lift put inside the shoe on the non-affected side. I guess it was about 1/8 of an inch or so, something a cobbler can make, so that there was equal weight in a simple standing position in both the affected and non-affected legs. And I wonder if that's still used or if you use that. And my second question is, at what point do you help patients walk up and down a flight of stairs?
Yeah, so the first step, putting a shoe lift under someone. I've never really done that. I'd love to read the article on that if there's literature on it. But I right off the bat, I just feel like that kind of creates a whole host of other problems. So basically, we got a leg length discrepancy now. So now the hip might be hiked a little bit more on that side. Patients who do have anatomical leg length discrepancies, they tend to have some back pain and there's a lot of issues that are going on with that. So I don't know if I would go that route. Sometimes with patients, especially with pushers who they got that pusher syndrome, I might put that non-affected performance side, step it up onto a step, sort of take it out of the equation a little bit and work on weight shifting that way. And that's going to force them to put more weight onto the recovering side. So I think that kind of does a similar function, at least in standing. If you start walking with it like that, I don't know about that. I would like to see other methods of improving weight shift to the right side. And then what was the second part of the question? I've already forgot.
Walking up and down a flight of
Stairs, yes. So there's walking up and down a flight of stairs safely. If you are in rehab immediately after your stroke, and in order to get in your front door or in order to exist in your home, you have to go up and down stairs. We need to be probably working on that from the moment you're able to walk. So you can't really go home without being able to do the stairs. So what we teach is the simple method, which applies to anybody with any orthopedic problem or weak side, going up one at a time. So you go up with the good. Good legs go up to heaven, right? Bad legs go down. So performance side goes up first. You need to take it one step at a time. And hopefully there's a rail there. And to me, that is a functional thing. That's getting you from point A to point B up the stairs. And if you can do that safely, great. It's not particularly therapeutic. Normal walking upstairs would be one step with each foot, right? So I might start a patient off if that is a goal that they have and they want to walk up and down stairs normal. Maybe they just have a few steps into the house. I'm going to start with like a 1-inch step, just a block or something, and let's practice stepping up to that 1-inch step with the recovery side, and then progress to 2, and then 3, and then 4. Everything's a progression in my world. So, we can work on that if that's a goal, really at any point if they come to me.
Okay, thank you.
I've found the simplest way to, when you work with people on gait, to get them to do more weight shifting, and you touched on it briefly in your presentation, Patrick, was take a longer step with your unaffected side. Most of us, when we learn how to walk, we don't want to put any weight on that unaffected side. So that sounds backwards, because you think you should take a bigger step with your affected side. But if you watch yourself walk, typically people take a reasonable step with their affected side and then do what I call play catch up. So here's your affected side. Instead of moving this one forward with the performing side, they move it even. They just play catch up, and they only progress when they're moving their unaffected foot. Well, if your affected foot is down and you put it next to you're not weight shifting like you will if you move that foot forward. So I find that most of the time patients' toes are pretty much equal, and I set a goal of just trying to get 2 inches, then maybe 4 inches, then maybe 6, and ultimately to the length of a foot. Like I said, I'm not a physical therapist. Patrick, you are, but observation-wise, that seems to be a simple way that I've done it with people when I'm walking with a gait belt, and you can certainly apply it to your own walking routine.
Yeah, absolutely. Like I said, that's a great starting point, is being able to shift weight, and you've got control. You've got great connection to that side that's working, the performance side. Let's start there, improve that, and get that going, and then we can start working on other things. There's always more to work on.
Patrick,
I
have a question. So I put it in the chat. So I had multiple strokes within a 24-hour period. One of them in the cerebellum with anoxia, ataxia, the whole 9 yards, and both sides were affected, but they focused more on my right side because I was right hand dominant. But I guess I don't have it on either side, so I can't stand one-legged on one side or on the other side, or hop and do things like that. And I only know how to come downstairs on one side because that's what they taught me to do. So I guess, where do I go with this?
Yeah. Wow. So, like I said, what I was covering was a lot of more of the traditional, the upper brain stroke. With your strokes in the cerebellum, we know the cerebellum affects balance, fine motor skills, a little bit with coordination. It's kind of the center of the
Sorry,
brain that
Jasmine.
it's the center of the brain that fixes what's going wrong, right? It's a refinement section of the brain. So the upper part of the brain says make this motion, and it's kind of uh, infantile almost. It's like just throw your arm out. I don't really care. But the cerebellum goes and says, hey, let's slow it down. Let's make it
She's
smooth.
such a pretty girl.
So
Pretty
if
doll.
it's
Pretty girl.
if your cerebellum is affected, your balance and your fine motor skills are going to be affected. So weight shift, I think, is still appropriate with you, and I think that using a mirror can help with that as well. Balance is going to be a big factor for you. Do you have when you walk? Is it really ataxic and shaky?
Some days I usually have heel drag. And because of my proprioception, because my other strokes were in my occipital lobes, it makes it that much harder. So I'm trying to balance with my vestibular, my proprioceptive, and then my cerebellum.
Yeah.
Sorry.
That's okay. Yeah, and then, gosh, if you have some strokes in the occipital region, for those of you who don't know, is in the back of the upper brain, and it is involved in vision. So, vision is super important for balance. If you can't see something, it changes your ability to balance on things. What I do for a lot of patients that have ataxia is I find a corner. Okay, so if you've got, and it's sometimes hard in a home because most of your corners are concave, right? Like if I look in the corner back there, it's two sides that come together. If I were to stand between them, my shoulders would be touching. If I find a corner that is pointing out, right, basically the opposite of that, it's a long, straight up and down peak, right, for lack of a better term. And if I stand up against it, so it is lined up with my spine, that can help with understanding proprioception. Okay, it can help with improving proprioception. What I have patients do is you stand and you lean against it, right? And maybe if you're off a little bit, you're gonna feel it in your back, and maybe you feel it more in your shoulder, and you got to move over to line it up to keep that pointing into the middle of the back of your skull and the middle of your back and in the middle of your pelvis, right? And then what I have people do is move away from it so they no longer feel it, try to maintain that balance in the middle, and then go back and feel it. And are you still touching it? If you are touching it, then we know that your balance is pretty good. But if you start drifting and you go back and you feel it touching into a different part of your spine and a different part of your back, then we're not maintaining that midline. Okay, so I do that with a lot of patients to help learn that to improve that proprioceptive input. So that's something that might work for you. You might already be past that. It's hard for me to know, but there's a few YouTube videos out there. Like if you look at Bob and Brad, they're great guys. They're not really neuro related, but they do have a video on putting an elastic band, a TheraBand, wrapping it around the foot and then bringing it up and wrapping it behind your knees and then coming up and wrapping it onto the front of the hip. And that increases proprioception by pushing upward through your leg. Okay. I can link to that. I'll give Ralph some links to some things, and he can post that with the YouTube video later. But that is a way that's a method that I use with ataxic patients to improve proprioception and make the motions a little bit smoother. Some people will put an ankle weight on the leg, and that can kind of work too, but this sort of does the same thing a little bit different. So there's some techniques like that that might help. I hope.
Okay, thank you.
A little bit, of course.
I already
Cool.
made a big long list of things you talked about to put videos and links, and anything you send me, I'll send along. This is kind of restating the obvious just because you didn't in the amount of time you have. If the takeaway is do bridges, 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 And Jackie, we'll get to you in a sec. There are two things that you can do when you do bridges that will help with some of the things that you were talking about, like weight shifting or weight evenness. If you put a ball between your knees and you push in, that tends to make your, when you bridge, that tends to make you put equal weight on both sides and not favor the strong side. Another thing, if you're doing bridges, if you take a TheraBand and you pull out, then that'll force your glutes to engage. A lot of people have a lot of trouble getting their glutes to engage. I, for one, went 13 years with hip dip, as I call it, from not having that pelvic floor strong enough on the affected side. And I discovered glutes at 14 years out with a non-neurophysical therapist who took the orthopedic approach and said nobody has glutes that are strong enough. So there's some other glute exercises you can do, but if you're bridging, just taking a TheraBand and pulling out. The other big one is sit to stands, doing the same thing, pulling out. Apparently, I'm not sure of the physics involved, but when you pull your knees out, it helps to disengage the quads and hamstrings and engage the glutes. You're nodding your head, so maybe that's correct.
Yeah. Cool.
So,
I think Jackie had a question, and
yeah, Jackie did have a
then Bill,
question.
maybe.
Can you hear me?
Yeah.
Yes.
Okay. I'm from Austin, Texas, actually Cedar Park. So this has been actually great. Thank you so much. My question is I don't have that dorsiflexion. I mean, like none. My foot drops really bad. What I have noticed in my progressions, when I'm in the pool, I have a lot of a good feedback. But my question is like, when I'm doing something like that, even a bridge or anything or a calf raise, my toe so far digs down, whether I've got an AFO on or not, it so far digs down that the back of my leg, my hyperextension, it goes into overdrive. And I guess that's the spasticity in my ankle. Well, and when I'm in the deep water, it does the same thing. It just wires up and points down, and I just can't even get it up. So my question is, do I stop when it does that, or do you work through that, or like trying to do a calf raise? I'm afraid the back of my knee is going to stretch out because it almost, I can feel it lock because it goes back so far. Because anytime I want to go up, my toe goes down, even doing heel raises. So when I do stuff like that, like if I do a bridge, I'll put a wedge underneath my foot so I always heel. So I block that. But I can't block it otherwise. And I don't know if I should just do these things or what to do.
Do you wear an AFO?
I do. Not when I'm in the water, I don't. But
Yeah.
I wear an AFO, not around the house. But
Okay.
if I'm out, I pretty much have to. Because
Are you able to?
I don't have the whereabouts to bring my foot up. It's going to drag all over the place.
Are you able to? Can you do a calf stretch?
Yes.
Okay. I would think that as you're walking and it's cramping up, or even in the pool, I would maybe not so much push through it, just stop and kind of stretch it out a little bit. If your calf muscles are overactive and increasing in spasticity, stretching those out might help. It's basically the concept of cramping. So if you can stretch them out a little bit, even if your hamstrings are doing it too, you can also stop and stretch the hamstrings. I wouldn't quite push through it like that. With the bridges, that's a great method to reduce that, is putting it with a wedge under it. Obviously with the walking, the AFO, hopefully that's going to reduce it. But yeah, it's a real challenge when there's not any active dorsiflexion. Have you ever tried electrical stim on the dorsiflexors?
I have. I did it for a year. Used a newbie for one whole year. And I just have not gotten any movement in my toes. They always want to cramp down. So like when I'm in the water, I'll use toe separators and that seems to help, do that, but.
Yeah, toe separators are something new that I've been getting into a little bit. Kind of like them. They work pretty good. I kind of did the electrical stim make your foot come up at all when it was on it?
A little bit, yeah.
Okay.
Yeah, it would, yeah.
I kind of almost wonder if there's something else going on there because, after a stroke, the neuromuscular unit should work with some electrical stimulation to it. It should actively lift up. So if there's something else going on, orthopedic or nerve wise.
No, and I remember it doing that. It's just that I haven't really continued it. I've got something at home. I've got a stimulator at home. I guess I could continue to use that.
I mean, if it didn't really benefit or change anything in a year, I don't know if continuing it's going to help. But if you stopped using it and then got more cramping, then it might have been benefiting you a little bit. So, to me, it's like stretching the calves out. If I were there, I would assess the ankle and make sure there's not some orthopedic issue going on with the ankle. Sometimes, the joints they just need to be popped and moved and stretched out a little bit.
Yeah.
So that's something that I would address.
Okay.
Yeah.
Thanks so much.
Of course.
Go A&M.
Right on. So I think my friend Bill he's been getting in and out of this chat and hasn't been able to maintain it. He's got some Wi-Fi issues, but he's an author he's a stroke survivor and a author of the book I Just Can't Read My Own Mind. So I wanted to give a little shout out to him for attempting to be in here and try to be involved today. So
Well,
any other
maybe I should
questions?
know who he is.
Oh yeah, cool, very cool.
Connect us.
He's a great guy.
Okay, well, man, I made bunches more notes, but we've been going for a while. I think I covered most of they're mostly add-ons to what you said. If anybody's got any more questions, speak now or forever hold your peace, like they say at a wedding.
I have one.
Okay, Wendy's got one.
Is there a estimated number of steps you should do in a minute?
You mean like when walking? So we look at gait speeds, and speed is really important. I touched on it a little bit. Slower walkers actually are at higher risk for falling. So that's not to say you should just go out and try to walk faster, but in therapy and in a controlled environment, if we can work on the speed a little bit, hopefully your natural speed improves. So if you go more distance in 1 minute, that increases your speed. If you are taking more steps, that might indicate increased speed, but if you're just stepping a whole bunch little, that doesn't, if you go 10 feet and you do it in 20 steps with your feet versus doing it in 7 steps, that's almost more of a problem. So I don't really measure how many steps you take in a certain amount of time or a certain distance. I care more about the overall velocity that you were going and the quality, of course. So that's not something I really look at, but if you're using like a step counter throughout the day to show how much you're doing, that's fantastic. Again, that's just a quantity measurement, which again is good and helpful, but quality over quantity all the time. So that's definitely something to keep in mind.
Should I worry that my therapist is trying to do that to me?
It depends, and it depends, what, if they're not looking at the quality, then I would kind of question that a little bit. But if they are, if they're trying to get you to move a little bit faster, that is a vital thing. It's actually considered a vital sign now. We look at blood pressure and we look at heart rate and we look at oxygen and temperature and pain. gait speed is actually a huge indicator. So if they're working on speed, if they're working on trying to get you to take more steps throughout the day, yeah, that's fine. But if they're abandoning quality, if they're sacrificing quality to improve your quantity of steps, I'm not really sure about the whole effectiveness of that.
I teach people that to work on form, because I find that speed comes with form automatically. When you have lousy form and you work on speed, you're going to multiply out bad habits, in my experience, personally and when I work with other people. So I think with form, the better form you get, you'll notice that your speed just kind of naturally increases. Winnie, I can talk a little bit about this. I don't know how relevant it is. I walk right at 3 miles per hour, and I test the MedRhythms product. And no matter what I do, when I start out walking, it tends to play, because you don't know this, Patrick, it plays music and measures your gait quality. And if your gait quality is good enough, you wear a couple sensors on your shoes, and they're accurate to a millimeter, which is really small. Lift height, step length, and all that. It'll speed you up. No matter what I do, when I try to walk slower one time, I end up walking 100 steps per minute every time I walk, and that's right at 3 miles per hour or 20-minute miles. And the product, the MedRhythms Stride product, has sped me up to 110 and to 115. When Patrick said right at a second, he's talking about both sides, and they're talking about one side. So 120 twice 60 is the intersection point of that. So I think people maybe pre-stroke might average somewhere around 120, and I'm walking around 100, and I don't know, like I said, if that's relevant or not, but those are the numbers.
Good. I'm excited because I'm going to do their product as well next week.
Awesome.
Yeah. It's an interesting product. One of the main things I find it does for me, I can't speak for everybody else, is I'm an overthinker. And that works great in the early days of gait. It tends to work against you in the later days of training yourself in gait. And I find that the music kind of keeps me from, well, first of all, once I hear the music, I want to put my affected foot down, and every time on the downbeat. It's automatic. Entrainment is the technical term for it. But it'll lock you right into entrainment. I want to put that affected foot down on the downbeat, so it locks me in. It also distracts me in a pleasant way. I actually find that I walk better with the songs that I grew up on than the strange songs that they throw at you. So I hit the skip button sometimes, like old Motown stuff.
Mm-hmm.
Man, I love walking to that because I know the songs. It's got a strong, R&B beat, and so it'll be interesting to see what you think about their product.
Right.
Anybody else? All right, well, Patrick, I guess, God, thanks is not enough. Thank you, thank you, thank you.
Thank you for having me.
Well,
Thank you. Yes.
You're welcome.
Jackie, I think you ought to get him to come on over your house and see what's going on if you're in Austin.
I know. Yeah. Well,
Available.
we are hotter than heck here. I know that.
Yeah, a little on the warm side.
Oh, yeah. But I'll look you up for sure.
Oh, yeah. My daughter lives in San Antonio, and she said it's been 102, 103 the last week. No fun.
No, it's just screaming hot.
Yes. All right. Well, Patrick, if you send me any links, I'll make sure to include them. I made a list of about 15 or so exercises and things that I can put, because I already did a thing on bridges, one-legged bridges, TheraBand, and balls. It's all in one bridge video. So I'll post some of that stuff, and also, I made a whole list of things. And anything you send me, I'll also post. So
for sure.
thanks again to you, Patrick, and thanks to everybody that showed up. I think this is really valuable. Was real valuable to me, so I can't imagine how it wouldn't be really valuable to everybody out there working on their gait. So,
Yeah.
thanks,
Thank you.
Patrick. It's very
Thank you, guys.
interesting. You know, I didn't know the answer to this, but your whole working with your mom with the kids,
Mhm.
it doesn't surprise me at all, and that's why I asked, because I know an occupational therapist who grew up with her mom who had a TBI. I knew a woman who became an OT because her stepfather, grandfather, and uncle all had strokes. So there's a lot of times, a lot of the things that drives us to help other people are very personal experiences like you had. So I was not shocked by that in one bit. So thank you again. If you ever want to do this again on other types, other aspects of walking, shoulders, anything you want to do, you're more than welcome here. Remember, Dr. Hetzler's done 5. So
Fantastic. I got
he's
a
got the
room to
bar,
go there.
he's got the bar set high.
Yeah, right.
So,
I would love to. Be great.
well, we'll talk about it because, you know, like I said before we started recording, the main thing I try and do with these is answer the question for everybody in the audience out there, what's in it for me? Because nobody tunes in and gives up their time unless they, you know, can learn something and have some takeaways. And I think there were a lot of takeaways today.
Great.
So
Hopefully
thank
it
you
was
for the
helpful.
3rd time, and we'll see everybody next week. We actually have another physical therapist, but he had a stroke and returned to physical therapy. And that wasn't enough, so he decided to just run a few marathons post-stroke. Yes, he did.
Overachieving. It's awesome.
He's out of New England area, Boston. I'm not exactly sure what town. David Dancero. He also has a podcast called No Stroke, KNOW. He's one of the few people I know who's doing kind of what I do with you and Dr. Hetzler and Mitch. By the way, Mitch did a whole thing on proprioceptive neurofacilitation. He's a big believer, and he had a stroke when he was 6, and he
Yeah.
became a physical therapist to help other people. Another one of
Yeah. It's
those stories
fascinating.
where early life affected somebody in a radical way to make them what I call a pay it forward person. So I'm going to connect you and Mitch. I made a note to put the two
Great.
of you together because I think you just hit it off philosophically. You know,
Yeah, man.
your outlook on stroke recovery is very, very similar. So I'll put you together and I'll stop talking so that everybody can go enjoy their lunch or their breakfast, whatever time zone you're in. And we'll thank again, Patrick, and we'll see everybody next week.
Very welcome. Thank you.
Thank you.